Good morning, everyone. I would like to start by saying a very big thank you to the organizers of Interest 2022 for the opportunity to stand before you and share some thoughts around achieving epidemic control among key populations in Africa. All that I'm going to be sharing today will be based on experiences we've gathered from implementation of programs for key populations across multiple countries, including across over 20 countries in Africa, and some experiences from outside Africa. All the views that I'll be sharing today are my own personal views, and they do not represent the views of our funders or my organization, FHI 360. During this very brief presentation, I hope to provide an overview of the epidemic control and what it means to key populations. I'll be highlighting a few thoughts about what we know about HIV among key populations in Africa. I highlight some of the strategies that are currently being used to expand access to relevant services for KPs, share a few thoughts about some of the strategies that require more focus or need to be scaled up in order to move closer to achieving epidemic control among key populations in Africa, and then end with a few concluding remarks. According to PEPFAR, HIV epidemic control is reached when the total number of new infections fall below the total number of deaths from all causes among people living with HIV. It could also be looked at using the HIV incidence to mortality ratio. When the IMR is greater than 1, it means the size of the population of people living with HIV grows. And when it is less than 1, the size of the population shrinks. We now know that some countries, including in Africa, have already met the epidemic control metric, while others are about achieving this goal. However, we still have a long way to go. This goal is going to remain a mirage across several countries without the scale-up of person-centered approaches and strategies, including ensuring that no one is left behind in the fight against the epidemic. In terms of the journey towards reaching the 95 targets, in 2020, globally, we stood at 84, 73, and 66 when you look at all populations combined. So this shows you that several gaps exist. According to UNAIDS, as at 2020, about 8 countries, including 5 in Africa, have met the 90 targets across all populations combined. The picture among key populations remain very, very unclear. So many countries still have difficulties even producing data that speak to HIV epidemic among key populations. Meanwhile, the achievement of the 95 goals is expected in all subpopulations, including key populations. Between 2010 and 2020, globally, we witnessed significant reduction in HIV-related deaths as well as new HIV infections. While Eastern and Southern Africa and Western and Central Africa witnessed significant reduction in both indices, the improvements were insufficient to meet the HIV epidemic control definition. Perhaps some individuals continued to be left behind in the response. So, who are the key populations? Within the context of my presentation, key populations include sex workers, and I'm talking about both female and male sex workers. And I'm sure a lot of people in this room will not believe that even in Africa, we have men who engage in sex work, not just as MSM, but even having female partners. So key populations in the context of my presentation relate to sex workers, gay men and other men who have sex with men. Again, within the context of Africa, There are a lot of men who are not gay, who will not identify as gay. They're bisexual, they have sex with other men, and they are also in heterosexual relationships. Transgender people, people who inject drugs, and people in prisons and other closed settings. People within these populations are disproportionately affected by HIV due to certain risk behaviors, marginalization, and structural factors that include stigma, discrimination, violence, police harassment, various human rights violations, and criminalization. And I think this is very important, particularly within the context of Africa. All these factors tend to limit access to safe, effective, and quality services. In 2020, key populations and their sexual partners accounted for 65% of new HIV infections globally and 39% of HIV infections in sub-Saharan Africa. And I'm sure some people are going to ask questions. Why focus on key populations when they only contributed 39% of new infections? So while the contribution in Africa seems relatively lower than in other parts of the world, most of the structural and legal barriers remain highly prevalent in Africa. And unless we focus on these populations or renew efforts among these populations, we're going to have very, very great challenges achieving epidemic control in this part of the world. Generally, key populations carry a high burden of HIV due to some of the factors I already highlighted. Across many African countries, HIV prevalence seems to be highest among sex workers, followed by transgender people, people who inject drugs, MSM, and then prisoners. However, the knowledge of HIV burden among these populations remain widely unknown across many countries. Now, while many African countries are now beginning to scale up programs for key populations, significant gaps remain when you look at the HIV prevention, care, and treatment cascades across the various key population groups. Data from South Africa among female sex workers and MSM showed a high number of these groups still do not know the HIV status, while some who know their status are not on treatment, and some on treatment are yet to be virally suppressed. And I think this slide actually highlights some of these challenges. So in terms of what we know about HIV among key populations in Africa, we know that while some countries are on the verge of reaching epidemic control, the progress among key populations remain generally unknown. Treatment cascade data exists for a few countries that are beginning to scale up programming for key populations. However, limited data on HIV prevalence among transgender people and people who inject drugs across many countries is still what we experience across countries. So what we know is clear. And what we know is that several gaps still exist. In terms of strategies that we have noticed that are beginning to work and are helping us to achieve or to improve access to prevention, care, and treatment services for key populations, I'm going to be highlighting a few of those strategies. Those highlighted in red are very, very promising, and they require further scale-up. Key populations community, including the various key population-led CSOs, are now being engaged in the design and the rollout and monitoring of programs. Many of them have expanded their scope beyond advocacy and human rights efforts and are now providing direct services. And I think one of the examples we had from Cameroon yesterday, which wasn't focused on key populations, demonstrated the impact of community-based service delivery to improving access to services. Countries and donors continue to understand the need for robust data around SARS estimates. We're now beginning to understand that targeting individuals and populations at hotspots help us to further understand programming, the various DSD models that are initially focusing on general populations and now being extended to key populations. And there are specific models for key populations that governments, including governments in Africa, are beginning to permit. And I'm going to give an example of the drop-in centers that are now being used as outlets for ART delivery across many countries in Africa. Over the past couple of years, PrEP has been scaled up to KPs. Peer-led approaches for linkage and treatment support has proven to be very effective when it comes to supporting continuation of treatment. Healthcare workers, as well as ancillary staff, continue to receive sensitization and trainings on the provision of KP-friendly services while we try to address issues related to gender and sexual violence experienced by many key population individuals. COVID-19 has provided an opportunity for virtual interventions to be accepted as an approach for reaching the unreached and for ensuring uninterrupted access to services. So, what do we need to do differently in order to move closer to reaching epidemic control among key populations in Africa? There are so many strategies, and I'm just going to remind you about the HIV prevention containment cascade for key populations. As we continue to think about achieving epidemic control among KPs, we need to keep in mind all the relevant interventions along the cascade and ensure that these services are person-centered, they're of high quality, and they are safe. The overall goal should be to sustain access to prevention services for those who are HIV negative, and those who are HIV positive must be promptly identified, initiated on treatment, and supported to remain adherent to achieve and sustain viral suppression. Now, this slide highlights so many strategies, and I'm not going to be focusing on all of them, but just to give you an idea that there are so many things that we can do better. But I'm going to be speaking to a few of them just to highlight how scaling them up or focusing on them will help us to move closer to achieving epidemic control. Number one, there is an urgent need to understand the population through additional investment in population size estimates, hotspot mapping for microplanning, especially for those key population groups that continue to be neglected. And you can see from the chart, there are so many countries where you have insufficient data just about the size estimate of key populations in those settings. Secondly, key populations in many African countries continue to struggle with accessing relevant commodities, especially condoms, lubricants, and STI drugs. In fact, as we speak, there are so many of the countries I support in Africa where lubricants are totally out of stock. Meanwhile, one of the reasons why we're facing this challenge is the stigma associated with the use of lubricants, because so many people believe only MSMs require lubricants, forgetting that everybody at one point or the other may actually require lubricants. So, access to prevention commodities must be looked into. Provision of STI services remain a critical element of a strong KP program, and we need more investment in this area. A modeling exercise that was conducted by Stover and colleagues showed that there will be a significant reduction in new HIV infections between now and 2030 if we scale up all prevention interventions, including condoms. Programs are now able to reach key populations with testing services through various differentiated testing models, including index testing. And index testing continues to produce the highest case finding rate, but other approaches, including HIV self-testing, social network testing strategies, are also effective at improving case finding. More efforts are needed to ensure safe and ethical index testing while providing other options for KPs to link their partners and contacts to testing services without the need to name or list their partners, including making sure that we leverage on the power of the online platforms. Experience across many countries have shown that oral PrEP is acceptable to key populations. DSD models that are working need to be optimized and scaled up to improve access, especially for those that will not visit traditional facilities for prevention services due to reasons that we all understand and know. We now have an opportunity to integrate PrEP into our decentralized drug distribution program, including PrEP delivery through private pharmacies, private clinics, and at community-based sites. The EPIC project in South Africa expanded access to PrEP for MSM through PrEP initiation and refill at the community level. And from this chart, you will see that 84% of the total number of PrEP initiations over a 9-month period were actually at the community level. The use of peer cadre to provide support for linking newly identified key populations to ART, as well as for the provision of adherence support, appointment reminder for viral load testing, etc., continues to prove effective. Now, you will see that the use of peer-led cadre has actually helped us to scale up and has contributed to ensuring that key populations continue to access treatment services. Data from EPIC projects across many countries in Africa actually demonstrated that we are now able to identify key populations. We're able to link them to treatment. We're able to support them to be adherent. We're able to ensure access to viral load testing. But the main challenge that we have right now, which I'm sure is not just for key populations, is in terms of coverage for viral load testing. Now, suppression rates, even among key populations in Africa, is extremely high. There are countries where viral load suppression among key populations above 95%, but coverage remains a major challenge. The DDD models, including those that are out of facilities, delivery models, many of which leverage the private sector, continue to be scaled up across many countries in Africa. Within the past 2 years, we have supported many countries in Africa to scale up DDD models, particularly within the context of COVID-19, in order to decongest some of the health facilities. DDD models range from providing drugs at community sites, to private clinics and at pharmacies, to automated distributors and home delivery. Selection of the most relevant models can be done locally based on the HIV epidemic and the COVID-19 epidemic context, based on the client preferences, available resources, and existing policies and systems at country levels. And some of these models also offer opportunity for viral load sample collection at community level. Now, some of the things I highlighted on this slide, there are measures that will help us to increase access to viral load testing, including testing at community level. And we believe taking HIV treatment without viral load testing is like being on antihypertensives without checking your blood pressure, or being on insulin without checking your blood sugar. It is unethical for clients to be on ARVs without having access to viral load testing. Therefore, the scale-up of some of the interventions and strategies highlighted on this slide will actually help us to further expand access to viral load testing. Now, why should we move very quickly into the online space? This is very, very crucial, not just for key populations, but for all individuals. Now, we need to move online to broaden outreach to previously unreached individuals, particularly key populations. We need to connect with growing mobile generation. And the experience that we've gathered from the EPIC project showed that online outreach resulted in higher case finding because programs now reach new individuals, individuals who have never tested or who don't test regularly. Meanwhile, they are at risk. Okay? But we have also found effective ways to target online promotions to subpopulations within high-risk sexual networks. Online And virtual solutions also provide clients with differentiated service delivery channels, including digitally enabled self-care, which means many clients' preferences for self-guided engagement in health services and reduce the burden on the health system. Finally, COVID-19 has enabled telehealth solutions that allowed many of our programs to mitigate the impact of lockdowns and physical distancing on HIV service delivery. As I move closer to the end of my presentation, here is the very familiar HIV service cascade. And you can see the simpler version of the cascade on top, and below you see the framework of virtual approaches that support each step of the HIV service cascade. There's virtually nothing you are doing in the clinic that you cannot start engaging clients with online, right from providing HIV prevention messages, right to conducting risk assessment online, booking appointment online, sending HIV self-testing kits to individuals that you are reaching online, providing support online, virtual case management online, screening clients for PrEP online, referring them to facilities for PrEP uptake online. There's a lot that you can do online. So leveraging on these provides an opportunity for us to actually scale up a lot of our interventions. Now, other than the 95-95-95 goals, there's a need to aim at achieving the 10-10-10 targets. And I haven't heard much about this throughout this workshop. All these three goals remain relevant to key populations, and they go a long way in determining the success of all the other interventions I've highlighted. Finally, we need to do more when it comes to addressing some of the discriminatory laws that continue to impact key populations and prevent them from accessing services. Some of these laws also hinder the ability of some providers to offer friendly services to key populations. This chart shows that sex workers in countries that criminalize sex work are 7 times more likely to be living with HIV than those in countries with partial legalization, and these are countries in sub-Saharan Africa. So, in summary, as we continue to journey towards achieving epidemic control, we need to focus more on specific populations, particularly those that are most vulnerable and carry a higher burden of HIV infection. We need to further understand the various key population groups, their contributions to the HIV epidemic, and how their needs could be better met. We need to engage them more. We need to look into capacity building of CSOs, organizations that are working directly with key populations. Make sure they have the right resources, and make sure that the government creates an enabling environment for them to thrive and to continue to provide support to the populations. We need to prevent new HIV infections using all the proven interventions, including PrEP and other new prevention technologies, including injectable PrEP. We need to ensure early identification and prompt linkage to treatment of HIV-positive KPs through the various DSD models that have been proven to be effective. Why can't they be scaled up across many countries? We need to expand access to viral load testing, including at community level, and also through the use of point-of-care viral load testing modalities. Most importantly, we need to create an enabling environment for better service access, including removing discriminatory laws, prevent and respond to violence that key population members continue to suffer from in the community, reduce stigma and discrimination, particularly from service providers. We need more commitment from our government. And I'm very happy on the first day of this workshop when I heard from the Ugandan government that key populations were actually referenced in terms of their strategies for achieving epidemic control. So we need more funding. Government needs to fund more research, because where your money is, most likely you want to ensure that whatever findings come out of the research will be implemented at the end of the day. We need to ensure policies are in place, guidelines are in place that will help us to scale up all these interventions. We need to develop systems and capacity to monitor and track HIV outbreaks. And I'm also happy we've had presentations on recency testing that will actually help us to track the epidemic. We need more research that will include and involve key population communities and ensure they do not just sit at the table, but they are part of conceptualization, they are part of the design, they are part of the implementation, they are part of the monitoring of research and all the implementation of programs. Once again, I'd just like to say a big thank you to the organizers of interest, to all our partners across the globe, to all my colleagues that have contributed to this presentation, and all our collaborators. And I thank you so much for your attention.